Thank you, Gada, very much for this extravagant introduction. I would like first to thank the managerials of the Egyptian Society of Nephrology and Transplantation for inviting me to give you this talk. This talk is about the life-threatening electrolytes or life-threatening electrolyte disorders. It might seem to be an easy task, but it wasn't. First of all, I would like to just give some knowledge about what is life-threatening. And threatening or life in medical study is met with when we are confronted with severe respiratory problem or severe cardiovascular problems or severe neurological problems. I think these are the main cause of immediate threatening to life. And we've got some symptoms and signs suggestive of this disease. Second, I usually ask myself a question: what are electrolytes? And simply, electrolytes are minerals that carry on electric charge when they are dissolved in a liquid, and the blood is a liquid here, or the body fluid as a liquid here. And the most important of them is sodium, potassium chloride, bicarbonate, among others. And they help regulate nerve and muscle function and maintain acid-base balance and water balance. So they are very important, and they can interfere with the previously given slide about life-threatening things. And we might think that managing mild single electrolyte disorder is usually a simple task for any nephrologist or even any physician. But in complex mixed cases, it is a challenging problem. And if you look at the periodic table of elements, we find many metals that might give electrolytes. But those which are of clinical significance is hydrogen ion, sodium, potassium, calcium, magnesium, phosphate, chloride, and I wouldn't be able to cover all of these because it would take ages to finish all of that. But these electrolytes are very important because they control nerve and muscle function, including the cardiac muscle. This is why it's quite important for life. And they are important for balancing the amount of water in the body. Some of these electrolytes are important for allocating volume to some part of the body, like I would say in a minute, the sodium in the ECF and the potassium in the intracellular fluid. They're also balancing the distribution of fluid volume between different body compartments, and they are very important in balancing acid levels in the body. First, I would like to introduce some electrolytes and nerve and muscle functions. And if we look at here, we find that sodium and the potassium are the main player of polarization of the membrane, the resting membrane potential. And they are also very important in their movement in the induction of action potential. And this is the mechanism by which nerve and muscle works. So without good amount or good concentration, good movement on sodium and the potassium across the cell membrane in a regulated manner, the polarization of the membrane or the resting membrane potential or the action potential wouldn't occur in an appropriate manner. And this is the monophasic action potential that is in the cardiac muscle. We will find that in phase 0, sodium influx into the cell produces this phase 0, while phase 2 is calcium. After the sodium influx, calcium will enter the cells from multiple channels, and in phase 3, potassium will exit the cell, giving the repolarization of the membrane of the cardiac muscles and producing cardiac activity. And also in the myoneural end plate, calcium is the main effector here after the action potential have been produced by sodium and potassium influx and the wave of electronegativity passing through all the nerves reaching to the end plate, where calcium influx now will produce the signaling to stimulate the muscles. And again, the calcium pump induced by ATP, energy consuming ATP, and after sodium and potassium has stimulated the membrane for that. Calcium pump here will produce the excitation contraction coupling in the muscles. So sodium, potassium, calcium, maybe other electrolytes are very important for excitation of the excitable tissues. They are also very important for secretion of some exocrine and endocrine cells and in other enzyme functions. Electrolytes can affect the ECG enormously. Like here, if you look at potassium and magnesium, hypokalemia or hypomagnesemia will produce ECG changes, while the hyperkalemia and hypomagnesemia produce different changes. And they all might end in arrhythmia, leading to cardiac arrest. Also, hypocalcemia and hypercalcemia produce changes in the ST segment and QT intervals, which can cause life-threatening arrhythmia and death. And here is an example of hyperkalemia, and you can see here that you reach up to a picture simulating VF when the potassium level increased above 8 or 8.5. Another case with bradycardia induced by hyperkalemia, and the hallmark here, as you'll see, is the presence of peak T cells. But there is no P wave. There might be atrial fibrillation, junction or escape prism, right axis deviation, symmetrically peaked T wave, and after that you will find inverted T, and then you find this bizarre shaped ST segment. Hypokalemia produces different picture here. You find a U wave, you find an extrasystoles, and then you find sometimes a VF and cardiac arrest. And this is an example of the U wave of hypokalemia. And hypocalcemia and the hypercalcemia plays mostly with the QT interval and the QTC. Hypocalcemia causes prolongation, while hypercalcemia will cause shortening of the QT interval. Now, I will introduce some facts about the role of electrolytes in maintaining of ECF volume and ECF osmolarity, as well as the other parts of the body. Now, in the body, there are some osmoregulation and volume regulation, and this is quite important for life. If there is disturbance in osmoregulation, there will be shift of water between the ECF and the cells, causing cell swelling or cell shrinkage, and it threatens vital organs like brain cells. And also, volume regulation is very important. It's quite important to keep the volume of the body, to keep the effective circulatory volume, and to perfuse the whole body system and cells by the blood supply. And this comes because there is differential distribution of the electrolytes across the same membrane in a very intelligent way. Sodium is very much concentrated outside the cell, while potassium is very much concentrated inside the cell. And this is what creates the resting membrane potential in the cell membrane. But also it causes the osmotic and diffusion properties of the cell membrane. If you look here, you will find that sodium and its associated anions constitutes more than 95% of the ECF osmolality. So ECF osmolality or extracellular fluid osmolality depends mainly on the concentration of sodium in the ECF. And this is sodium, the metal sodium, which is a very reactive molecule with a molecular weight of 23 nearly. And it's very famous because we cannot do without it. We eat it in the breakfast, in the dinner, and in the snacks, and the supper, and in every meal. And some of us would take more than 10 grams a day of sodium chloride. This sodium is very important for our body because it binds water and is associated with water, making the volume of the body. So if we lose sodium from our body, then we have to lose our volume. And this happens when we are given some drugs that move sodium outside the body, like diuretics. So the concentration of sodium in our body depends on two things: the amount of sodium present and the amount of water dissolving such sodium. So water is the solvent of sodium. Mostly, the water will control the concentration of sodium in our body. Because our body is not just water, the volume of our body is water plus solutes, and the most important solute in the ECF, as I said, is sodium. So the volume of the ECF depends on the amount of sodium therein. If you take sodium out, the volume gets down. If you get sodium in, then volume increases. And this can explain that the sodium doesn't only play a role in volume, but also it plays a role in osmolality. So both osmolality and the volume of the ECF are dependent on the concentration for osmolality and the amount of sodium for volume keeping of the ECF. And severe examples of sodium retention in the body causes fluid overload, which can be devastating with severe hypertension, or loss of sodium can cause a volume deficit with dehydration, and it can kill the patients. And you can find this sign of skin turgor. One of the important things is pulmonary edema, which can happen after consumption of a high amount of sodium in a patient who cannot deal with such a sodium due to kidney disease or hormonal disturbances. The other phase of sodium in the body is its effect on osmolality. And the osmolality of the ECF is dependent on the amount of sodium inside it. So if the amount of sodium, or the concentration of sodium is increased in the ECF, this causes hyperosmolality, causing shrinkage of the cell, and vice versa. When the concentration of sodium drops in hyponatremia, there is cell swelling. So hyponatremia affects mainly the brain cells, with dysfunction of the brain cells, because the brain will swell. It's soft tissue that swell easily when there is decrease in the osmolality outside the brain tissue, with a lot of signs and symptoms. Also, the GIT may be affected, and the brain may take time to get rid of such accumulating water inside the brain cells. And this is in chronic hyponatremia. The effect of hyponatremia on the brain is not as devastating as in acute hyponatremia, where the brain swells a lot, might cause even something like herniation. And we assess the volume of the patient to know which type and which cause of hyponatremia, and we classify it into hypovolemic patient, hypervolemic patient, and eovolemic patient. And we reach a diagnosis, then we start to treat, and we treat energetically if we think that the patient is apt to develop herniation. So there will be manifestation of herniation, then we have to treat, but when we treat, we have to be gentle with a controlled rate of treatment, otherwise the patient will pass into osmotic demyelination syndrome, which is dreadful. It is fatal thing. So when somebody develops such thing, it will be a pity. So we have to control things, and we balance the risks of correction with the risks of hyponatremia itself. So in acute hyponatremia, the balance is better for correction. But in chronic asymptomatic hyponatremia, it's better to be very slow and very calm in treating the hyponatremia cases. And during the 2014, there have been some publications about the guidelines of clinical practice, or how to treat hyponatremia in a gentle way without disturbing the patient's life. But later on, a year after that, there have been a questioning about neglection of intracellular events during hyponatremia. There have been a lot of intracellular events that might cause damage, causing osmotic demyelination syndrome, and the author of this publication suggests that we look after things like phosphate, potassium, magnesium, and glucose, while being very gentle in controlling hyponatremia. Hyponatremia is the opposite, causing shrinkage of brain cells and causing also brain disruption, and can cause death. So we diagnose it. Also, we look at the volume of the patient, and then we classify and we treat the cause. But if the cause is reached or not reached, we treat the patient with giving him hypotonic solution like water or glucose, or sometimes saline. Potassium is another important electrolytes, but it's mainly here, the major intracellular cation. At its control, it controls the cell volume, and it is very important in the excitation coupling. And if the patient has got emergency manifestation like the ECG change I showed you previously, then you've got to move to therapy straight away without thinking of diagnosis at times. It's diagnosed later on. But if you diagnose a pseudo-hypokalemia, then no further workup. You do another sample to make sure that it's pseudo. But if it's not emergency and not pseudo, then you take some history and the clinical examination, laboratory tests, and you see if the patient has got clear evidence of low intake, then you treat accordingly, or the patient has got clear evidence of transcellular shift, then you treat like insulin excess or beta adrenergic agonists or hyperthyroidism or barium intoxication or whatever. So we treat hypokalemia easily by giving potassium, but the problem is the rate of correction. If you give potassium in a too concentrated, it can injure the vein, or it can, if it is in a CVP, it can cause temporal hyperkalemia near the vicinity of the heart, causing arrhythmia and even this. So you go in a gentle, distributed treatment all over the day. Hyperkalemia is caused mainly by renal disease, but other causes might also be present. And when we diagnose hyperkalemia with an ECG manifestation, this is quite enormous and fearful things. So what we do is, if there is ECG threatening or change, we give the patient calcium once or twice, and then we give something that introduces the potassium to the cell, getting potassium inside the cell, and then we try to remove the potassium from the body. The calcium works for only a temporary 1 or 30 minutes or 60 minutes, but it works very efficiently in stabilizing the heart in front of the hyperkalemia. Insulin and salbutamol are very important in the management of acute severe hyperkalemia with ECG manifestations, but it's temporary and works only for a few hours, after which potassium will be released back again from the cell to the ECF, causing the devastating problem. And if you combine both albuterol, which is beta stimulant, and insulin together, then we can get a better and prolonged effect. Calcium, magnesium, and the phosphorus are also important electrolytes and the minerals that can cause life-threatening problem. And hypomagnesemia is unfortunately forgotten, but it can cause cardiac arrhythmia and it can cause seizures. And it is usually associated with hyponatremia and hypokalemia and maybe hypocalcemia. Hypermagnesemia is less common, actually. I've only seen few cases, and it occurs when there is severe renal disease and the patient is on a very high magnesium-containing diet, and the very high levels of hypermagnesemia can precipitate cardiac arrest in these conditions. But it is important for any case of decreased consciousness that we look for the amount of magnesium or the concentration of magnesium in the blood, because hypermagnesemia can be a cause of decreased consciousness in such patients. Hypophosphatemia and the hyperphosphatemia are less common as an electrolyte, but hypophosphatemia can cause manifestation in the blood, in the skeletal muscle, in the cardiac muscle, in the CNS, and in the bone. And it's again another forgotten electrolyte that we have to look after it. Hyperphosphatemia is attended with calcification, metastatic calcification, and needs to be treated. And thank you very much.